in 1970. That is far way back. And his results is quite good. After 10-year follow-up, he has shown that 60-year male with aphakic contact lens with residual vision of 20/40. That is a very good result in 1980. But then between 1984 and 1990, DRVS published 5 reports. And recommendations are not in favor of early vitrectomy. It is unfortunate, isn't it? And results were not so encouraging, as 10 to 20% patients turn into peer-denied patients within 2 years of follow-up. Then the basic indications of vitrectomy in DRVS were non-resolving vitreous hemorrhage for more than 1 year, combined retinal detachment and fractional retinal detachment involving approaching macula. And they recommended that early vitrectomy is only helpful in type 1 diabetes, not in type 2 diabetes, which we are seeing more and more. But now, all the young vitreoretinal surgeons are very aggressive in treating complications of diabetic retinopathy. Why? Because machines are much more efficient and predictable, and the results are also very encouraging. And we follow the rule that early you intervene, you are going to get better result. Absolutely different from DRVS. But why? Why DRVS was so conservative, and why in 2014 we are so aggressive in treating vitreous hemorrhage or diabetic retinal complications? We have to find out those answers. Number one, preoperative evolution, which is very important, by ultrasonography B scan and OCT. Until date, when media is hazy, USG B scan remains the gold standard of preoperative evolution. When the media is hazy, we can understand that how much is vitreous hemorrhage, whether there is TRD involving or there is combined RD or not. We can understand everything by modern high resolution USG. In 1993, invention of OCT changed the whole concept of two-dimensional diabetic retinopathy classification by ETDRS absolutely in different way. Now, because ETDRS classified diabetic retinopathy according to fundus photography, there is no concept of OCT, and so vitreoretinal interface was neglected. And now onwards, we started three-dimensional classification of diabetic retinopathy, and modern 3D HD OCT helps us understand pathoanatomy and pathophysiology of vitreomacular interface in diabetic retinopathy in much better way. So with this small video clipping, we can understand that whether taut and posterior hyaloid is attached to macula or not, and the cause of that neurosensory detachment is due to posterior hyaloid or not. All these evolutions is preoperative. Look at this thing. We can get that here it is attached to the macula and causing TRD. Now, OCT added few more indications for vitreoretinal surgery. That is vitreomacular adhesion and traction, thick and taut posterior hyaloid, epiretinal membrane, non-resolving diabetic macular edema, and pseudo hole or partial thickness hole or full thickness macular hole. During DRVS, actually they are very scared of that. They recommended that you should operate those cases where total pan-retinal photocoagulation is already done, and they are very scared about perioperative bleeding. Why? Because that time there was no endo photocoagulation, and endocautery is also very primitive. But now in modern era we are having beta laser, green laser photocoagulation and LIO for peripheral retina. When central retina is involved by vitreous hemorrhage, we can do preoperative photocoagulation. And most importantly, now we are having anti-VG, which we can use preoperatively 3 to 5 days prior to surgery to reduce vascularity of the membrane, and which make much difference and to make the surgery much more predictable. And this is preoperative photocoagulation for Pascal or LIO when only peripheral retina is visible, and preoperative Avastin is very useful. But the basic preoperative step remains the same. DRGs until death. That is, you have to vitrectomy to clear media, and if there is membrane, then go for segmentation and delamination, and then laser photocoagulation. Now we have to understand the confidence of the surgeon depends on the machine itself, and modern machine is basically absolutely all-in-one. It is having xenon light source, it is having endolaser probe system. You can see two endolaser probe system, one is without illumination, another is with illumination, and both are in 23 gauge. And the very important part is that cut rate. And increase of cut rate is basically not a technical height. Basically, you can see the how vitreous traction in 1000 CPM and how it is in 5000 CPM. And now we are using 7500 cuts per minute cutter. And actually, all the collateral damage on the TID or combined ID are due to these vitreous traction. So more advanced cutter reduces the traction on detached or combined ID and reduces the collateral damage and makes the surgery much more predictable, and results are quite encouraging. The cutter port optimization, it is nothing but just a slight modification. The modern technology made the cutter closer to the port, closer to the tip. That helps us to save the membrane from the retina without using scissor, and making segmentation or delamination is very easy now with cutter. And another terminology that is called duty cycle change. Duty cycle is something that you have to choose how long your port will be open. Means that maximum one is 70% and minimum one is 30%. Time of your total time is port open. And cartridge remains the same, 2500. You can see the turbulence of vitreous in when the port open means duty cycle is maximum, but turbulence of vitreous is minimum when the duty cycle is minimum. But you have to balance everything. Means when you are operating in clean cut core vitrectomy, then your duty cycle will be maximum. There is no harm in doing a lot of turbulence in vitreous. But when you are going towards the surface, then you have to keep your port minimally open. But at the same time, whenever you are dissecting your membrane, which is far more tougher, then you have to keep your port slightly high. I'll show you in the video in later part. And this is high-speed camera inside the eye, taking the photos of duty cycle. You can see the cartridge is fixed 2500 in both the cases. But you see the first one, it is going so slow. That means the port is open for longer time, that is 70%. And another, it is 30%. So you are thinking that this cutter is cutting slowly, but actually cutter is same in both the cases. It is called duty cycle. You are dealing with the duty cycle. And finally, the extremely precise instruments. And that was not available during my fellowship periods. These instruments, we surgeons are absolutely, I'll show a small clip of video with modern instrument how iron pilling, even in diabetic macular edema, is so easy because of this fine grasping these forces. Without those concepts, it is not possible. And nowadays, most of the surgeons, ear surgeons, used IRM peeling in diffuse diabetic macular edema, which is not responding, means transluminal acetate vitrectomy plus IRM peeling. That is the treatment of choice nowadays.